Okay, we're going to continue our conversation about chapter 45. We left off at tubo-ovarian abscesses, so we'll continue to talk about this. Now, this is more of your stage 3, stage 4 PID, pelvic inflammatory disease. And it's definitely the most severe because the infection has continued to go through the uterus, through the fallopian tubes, and now has started to sit in with the ovaries and the peritoneum that is around, so, the tissue around the pelvic area. So let's talk about those. So adhesive edematous inflamed serosa may further adhere to ovary or other peritoneal surfaces, which distorts the anatomy. As the infection worsens, the periovarian adhesions may form and the ovary cannot be separated from the inflamed dilated tube, and it's called a tubo-ovarian complex. Now, with these, it definitely does look like a large mass by the ovary. You can kind of see the ovary, but then you see this large, nasty mass. And there's lots of pictures of these in your book on chapter. Let me look here. Let me look. On page 1144 and page 1145. And, it's just really difficult to say because we've learned about so many different masses and all the different malignant and benign things that can go wrong with the ovaries, right? In the last couple of chapters. So it's kind of difficult to think, okay, is this, a dermoid? Is it a, cystadenoma? But you have to also consider the clinical symptoms of the patient. Again, with a pelvic inflammatory disease, the patient's going to be a lot of pain, jumping off the table when you're doing an exam, probably going to have fever, white blood cell counts up, and potentially has a history of STDs. And these should all be communicated with you before you are doing the exam. So you kind of know that if you saw something like this, like a mass like this, that that's more what you're dealing with than some other kind of benign or malignant tumor. Fortunately, these respond really well to the antibiotic treatment without need for surgical drainage. And serial ultrasound images during treatment allow observation and resolution. And I agree with that. The last patient I did that did have one of these, she was in the hospital for, I think, 5 days and had to have IV antibiotics. And when I scanned her again, it still hadn't resolved all the way, but um, I took measurements of it and then we scanned her again and it started keep continuing to get better. So that's usually how we um, kind of monitor the situation is by measuring the mass to see if it resolves. Another thing was with this patient, the last patient that I did that had one of these, she was not in pain as much anymore. And I think it's because it wasn't um, an acute infection, if that makes sense. It was more chronic by that time or resolving. Okay, so here is a complex yucky mass that this is the uterus, and that's a mass there that is looks like it's anterior to the uterus. This is a mass that is right by the ovary. You can see here. It's more of a tubo-ovarian abscess. You can also right here see some free fluid that we would want to mention. And here is still that mass. Here's another one. And kind of, if you're just looking at it, like it could potentially look like a dermoid too, but again, we have to, with ultrasound, always consider like the clinical symptoms of the patient is such a huge um, part of the exam and delineating what could potentially be um, what we're looking at. And for your own sake, so you know kind of what you need to do. Now, the thing with tubo-ovarian abscesses, you want to try to separate it from the ovary if you can, just to see, because that is going to matter to the doctors. So what you can do, and it's easier said than done, is put slight pressure to kind of push in between, the mass and the ovary to see if you can separate it. Now, this is again, that's in a perfect world. Like we've said before, these patients can barely handle the exam. So most of the time, what you're going to be doing is just running through as fast as you can, for the patient's sake. But if you, that is something to keep in mind if a patient's not in as much pain. So peritonitis is the inflammation of the peritoneum, the serous membrane lining of the abdominal cavity and covering the viscera. If an infectious process spreads to involve bladder, ureter, bowel, and adnexal area, it becomes a pelvic peritonitis, and I can't imagine how painful that could be. And again, this is that inflammation is caused by the infectious organisms that gain access by way of rupture, perforation of the viscera, or associated structures via the female genital tract. So you're going to see some gas-forming bubbles. You're going to loculated areas of fluid within the pelvis, the pericholic gutters, mesenteric reflections, and the evaluation of the space between the right kidney and liver and left kidney and spleen for free fluid. This is free fluid that was associated with appendicitis here. And appendicitis, acute appendicitis, can cause peritonitis if it's ruptures. This is free fluid that is associated with, looks like ovarian torsion due to a mass. And we talked about endometritis a little bit, but let's go through it one more time. Now there's, you can have two types: non-obstetric infection, and that's usually what occurs with PID, or gynecological instrumentation. And what I mean by that is an intrauterine device, or IUD, for birth control. Or you could have obstetric cases occur in the immediate postpartum period. So those are the two types of endometritis that can be associated with pelvic inflammatory disorder. With the non-obstetric cases, anytime they manipulate with the endometrium, like I said, with an IUD, they do some kind of DNC or something with instrumentation, there isn't a risk of an infection. Endometritis is the most common cause of fever in postpartum patients, and I think it's over 101 is what they consider fever. So with endometritis, the sonographic findings are going to be that it may appear thick, contain fluid, air, or clot, and appear normal. It depends on where we are in the infection. The endometrium can be at normal up to 20 millimeters. Usually what we like to consider, though, is it's thickened after 15 millimeters, just for your own sake, and that's what I want you to remember. But if it's greater than 20 millimeters, it's really thick, and that could be a suspicion for endometritis or hemorrhage or retained products of conception. The risk for endometritis increases with premature rupture of membranes, which is when the amniotic fluid is ruptured, like a patient's water breaks before it should, or if there's retained clots or prolonged labor. And this is the endometrium. Look how pretty that endometrium is, though, because I really like, so this is what we call like a 3D ultrasound of the endometrium. If you're blessed to have a transvaginal 3D probe, which for a while at a job I had for like 7 years, that's the best thing ever. And the reason I love it is because Well, there's multiple reasons. One of them is you don't have to manipulate the probe as much. You can just turn a knob and it goes to the right, it goes to the left. So you're not manipulating within the patient when you're doing a transvaginal as much, which is a lot more comfortable for the patient and also gives you so much more of a view. The other thing that I love about a 3D probe, transvaginal probe, is that you can get awesome coronal images of like the endometrium. Look how cool that is. So this helps when you're looking for IUD. If you feel like there could be some kind of congenital anomaly of the uterus, a bicornuate, these kind of help you visualize that. Okay, so let's talk about endometriosis real quick. There's basically two types that we're going to talk about. But the definition is that there's a presence of functioning endometrial tissue in abnormal locations. So not a lot of can be out in the pelvic abscesses, could be in the rectum, could be in the bladder, could be on the ovary. You know, there's all sorts, it's ectopic tissue that can almost be found anywhere in the body. Look at that. Here's a picture of all the different places that endometrial tissue can be found, or probably even could be found other places, but most common. And so you can see when a patient is having their period, and this is proliferating and bleeding these tissue, how that would cause severe pain in a patient or dysmenorrhea. So the clinical findings are severe dysmenorrhea, chronic pelvic pain from peritoneal adhesions, bleeding, and dysperiod. Which I'm horrible at saying. I'm sorry, sometimes I just can't say words, but that's painful sex, basically. The cause may arise from the peritoneal seeding from retrograde travel of endometrial cells through the fallopian tube. So when a patient is having their period, instead of the blood going through the vagina out, it goes through the fallopian tubes out into the pelvic region, causing cells to seed and grow. Traumatic spread from uterine surgery or amniocentesis. Metaplastic transformation of the peritoneal epithelium into endometrial tissue. So basically, tissue is turned into endometrial tissue. Endometriosis has two forms that I want you to know, internal and external. The internal endometriosis occurs within the uterus and is called adenomyosis, which we've mentioned before. External endometriosis occurs outside the uterus and may be found in the pouch of Douglas, surface of the ovary, fallopian tube, broadened ligaments, or the rectovaginal septum. The more common form of the endometriosis is the external, and they can vary in small foci to discrete masses. If it's very small, if the implants are very small, we really have a hard time diagnosing endometriosis on ultrasound. We can see distinct masses, but we can't see implants. You just can't. It's just hard. So endometriosis is not well, you can't really clinically or you won't be able to diagnose it from ultrasound. It's going to be more like a laparoscopic surgery that is going to be the best way to tell the patient if they have this. Endometrial tissue and endometriosis cyclically bleeds and proliferates as stimulated by changes in hormonal influence. The internal or direct form is called adenomyosis, and this is when endometrial tissue grows from the endometrium into the myometrium, the muscular layer of the uterus, which we've talked about. The clinical symptoms are going to be heavy menstrual periods, bleeding, painful menses, and uterine enlargement. Adenomyosis is most common in women who have had uterine surgery. Sonographic findings are you're going to see the myometrial cysts, especially in the posterior portion of the uterus. You also are going to get that Venetian blind look, which I've showed you before in images. And it just kind of looks not very pretty. Usually in a uterus, It has a nice homogeneous echo texture in the myometrium. And I feel like, especially in the posterior borders of the uterus, it's more heterogeneous. MRI is more specific than the ultrasound in making this distinction. So you remember that my favorite mass of all are endometriomas because they just look kind of pretty. They're nice and they are easy to pick out. They're not simple. There's internal echoes, but they are just uniform, and it just looks, it's just pleasing to the eye mass. So its localized form consists of discrete mass called the endometrioma or chocolate cyst, and it's asymptomatic most likely, multiple sites with unique sonographic appearance. As you can see on your in your book at 1140, page 1148, there's a beautiful picture of an endometrioma. And it may become moderately enlarged and may create surgical emergency by rupturing or causing ovary to twist on vessels. So the sono findings are diffuse endometriosis, more common form, rarely detected, but endometriomas are easy to detect. They could be bilateral or they could be unilateral. And they have different patterns ranging, but the most common is that really pretty uniform internal echo look. There's one. See, it's not simple. You can see that this, because of the bleeding, it has those internal echoes, but it's just very nice to look at. Ovaries typically adhere to the posterior surface of the uterus and are stuck in the cul-de-sac and may be difficult to define. Obscured organ borders and multiple irregular cystic masses are also suggestive of a pelvic infection or cancer. So interventional ultrasound, sometimes we can use transvaginal or transabdominal to help with benign appearing cysts. So if I've done this before, if a patient, like even in the office, I just scan with the doctor, and if it's a simple cyst, I just help them locate the cyst and then watch them put the needle in and aspirate it. It's very helpful. I've never done a transvaginal drainage of like a TOA, but I know that they do that sometimes. Sometimes they will try to aspirate with ultrasound guidance. And I think that's it. If you guys have any questions, just put them on the discussion and I will answer them. But we will see you next time. Bye.